Hello, everyone. My name is Lisa Kennedy, and I'm the Director of Marketing Communications with CareTech Solutions. On behalf of our presenters, I would like to welcome you to our webinar titled Strategies to Support MACRA Standards. Before we get started, I would like to cover a few housekeeping items. The structure of our session today begins with a presentation that will run for about 45 to 50 minutes, leaving us with about 10 to 15 minutes at the end for questions. To ensure no disruptions during the presentation, we will be muting the line. Should you have an issue hearing the presenters or seeing the information, please contact us through the chat feature within the GoToMeeting section. In addition, throughout the presentation, please collect your questions and submit them through the question feature, as you will see in the lower right-hand side of your screen, and we will address them at the end of the presentation. We will also post them to the MACRA page for reference. Following the session, we will be sending out a short survey to gauge your feedback on the event itself, the topic, the presenters, and gather any suggestions you may have to make these events even more beneficial for you in the future. Thank you for taking time today for the session. With that, I will turn it over to our presenters, Monica Nichter, Director of Revenue Integrity and Payer Contracting at Holy Family Memorial, along with Jim Darren, Director of Information Technology, Healthcare Planning with CareTech Solutions.
Okay, this is Jim Darren, and I'm going to start the presentation by giving you a little bit recap and an overview of MACRA. One of the key features of being successful in your attempt to be compliant is to really understand the law, and that's what we're going to try to start with. Monica's going to talk about what's being done at Holy Family, and I'm going to wrap it up with some of the IT steps that you should be taking in order to be ready for it. So the objectives first, I'm going to talk about the differences between the two alternatives you have. That's the alternative payment models as well as merit-based incentive payments, which is called MIPS. I've got some samples for you to think about the financial impact of the bonuses and penalties. And then we're going to talk about how Holy Family is using information technology to prepare for MACRA. Okay. So a little bit about Monica. You can see on the screen that she works at Holy Family Memorial Hospital in Manitowoc, Wisconsin. And Holy Family has been incredibly innovative in their use of IT. They were one of the first hospitals to achieve stage 6 on the HIMSS analytics maturity model. And I've been working in healthcare IT for about 35 years. Okay, so here's some of the highlights. The rules really started back in April. It was proposed. Even though you need to be ready for this starting January 1st, 2017, the final rule is not expected till November 16th, so there's still a lot of questions about what the rule is going to look like. In anticipation of that, on September 8th, CMS announced they're going to provide flexibility to providers to allow them to avoid the negative payment adjustments, and the timelines will be moved back. MACRA repeals the current payment system for Medicare providers, the sustainable growth rate model. And as I said before, you can select one of two options, MIPS or APMs. The program is totally budget neutral, meaning all the money that's being put into it is going to be shifted so that there's equal payments dispersed that are offset by the penalties. So it's budget neutral. And down the road, even though you may not be a big Medicare, have a payer mix, both Medicaid and other private payers are working on adopting similar programs as well. The final thing I wanted to say about the highlights is that this does not mean that you can't get ready for stage 3 meaningful use, as one of the key components really overlaps quite a bit with what stage 3 it looks like. Okay, so initially there's two paths for providers. MIPS is really what most people are going to fall into. Some highlights of it is you're going to have a 100-point scale that's a bit confusing, so I want to go through that a little bit. The data is always going to be retrospective from 2 years prior. So in 2019, the adjustments will take place based upon your 2017 data. There are 4 categories that I'm going to go into, and as I said, most providers are going to be subject to MIPS. Advanced alternative payment models, or APMs, can receive more money. And there's fewer providers are going to meet the qualifications for this. You must have a certified EHR, and most of these are set up so that they bear more than nominal financial risk or your medical home model. Okay, so who's not eligible for MIPS? Initially, it's going to be for caregivers or first-year Medicare Part B participants. If you are below a patient threshold volume, so that means your Medicare billing charges are less than $10,000, or you care for 100 or fewer Medicare patients, and some of the advanced alternative payment models. The key thing to understand here is that MIPS does not apply to hospitals or facilities. However, hospitals are very affected by this, and that their providers are going to be subject to this. So if your physician office is linked to a hospital, it's going to hit their bottom line. Now, who is in right now? In year one is going to be physicians, PAs, nurse practitioners, dentists, and nurse anesthetists. And in year three, additional providers are going to be added to the program: therapists, audiologists, midwives, social workers, psychologists, dietitians, and probably more to come. Okay, so the alternative payment model incentives, I just want to quickly say that if you're not in an APM, you'll see the charts in a minute, but you will have a MIPS adjustment. If you are in an APM, you get that plus specific rewards, and then there's a thing called the advanced APM that also is eligible for a 5% lump sum bonus. Okay, the financial summary for this now, the initial slides that were put out have been tweaked now because of the changes that were announced on September 8th. But as of 2019, the MIPS adjustments are going to affect your Medicare reimbursement by 4%, either positive or negative. Those are the maximum amounts. And then annually it goes up to a maximum of 9%, okay? In addition, if you're an advanced APM, as I said before, you can get that 5% bonus. Currently, for the years 2016 through 18, you're going to get your initial fee schedule updated as 0.5% every year, okay? So these are the maximum adjustments, and they might be scaled up or down. So what did CMS come out with to make this a little bit easier transition? Well, we'll know exactly when November comes around and they announce the final rule. There's speculation that the program time frame is going to be pushed back a little bit, but here are some of the options that were provided. One was that providers can just test the system initially. So you have to submit some data, and what the benefit of that is they're ensuring that the provider systems are working and able to do the transmission. You can participate for part of the calendar year. The thing here is we don't know what part means yet. Does it mean 30 days, 90 days, or 1 day? So that's going to be clarified in about a month's time. You can, if you're ready, participate in the full calendar year, and if you do so, there can be incentives attached to that. Or you can choose, if you're eligible, to participate in an advanced alternative payment model. Okay, so if you do that, you got the ability to get a 5% incentive on your payments. Okay, so I'm going to talk a little bit more about some of the MIPS system and some of the rules. Initially, there were 3 components that have been tied to Medicare payments, and what this system, MIPS, has done is it's added one. So you have quality reporting, that was PQRS. You've got resource use or cost, that was your value-based modifier. Advancing care information aligned with meaningful use. But a 4th component has been added called clinical practice improvement activities. And I'm going to go through and briefly explain what you need to do in each of these 4 areas. Okay, initially the way these things are scored or rated is that quality is going to be 50% of the amount that this composite score I'm going to talk about takes up. Advancing care information, which is meaningful use criteria, is 25% of the score. Clinical practice improvement activities is 15%, and resource use is 10%. In a few minutes, I'm going to go into a little bit more detail about each of these so you understand what the requirements are going to be. Now, one thing I wanted to note was this is the scoring in 2019. What's going to happen is throughout the years, this ratio is going to be modified and changed, and quality is going to go down and others are going to go up. Okay, so a little bit about the payment adjustments. If you're at the threshold, meaning you're right in the middle of the bell curve and you've kind of done everything, but your score comes out to be right in the middle, you're not going to have a payment adjustment at all. So it'll be the same as today. If you're below it, you're going to have money held back, so you're going to be below the threshold. If you're above the threshold to a certain percent, you're going to have a positive payment adjustment. And then if you're in the top few percent, which has not been defined yet, we'll know more in November, you're going to get an additional bonus payment, which could be significant. It could be up to 12% more in year one. So this threshold, we don't know what it is yet because CMS updates it annually based upon how everyone's doing. So that's where you'll come out with the median score and figure out what the threshold is. Okay, so this chart really is meant to kind of give you a little bit insight as to how the scoring works, and you just have to bear with me just for a minute to explain it because you probably can't figure it out on your own. On the right-hand side of the screen are those composite scores that we showed you in that chart. As you saw before, quality was 50 points towards that composite score towards the maximum score of 100. Now within there's other point values, and they vary a little bit based upon what your practice looks like. So if your basic quality measures, there's going to be 200 of them that you can select from. So that's how many you get to review and say, which ones do I think I'll be successful with? You have to just pick 6 of those. And each one of those is valued at 10 points each. So your maximum is going to be 60 points. Then on top of that, what you have to do is kind of add up that if you're, you have less than 9 providers in your group, you have to pick 3 additional selections out of that 200, 10 points each, and so your maximum score comes out to 90. If you have less than 10, it's going to be 2 selections, and your possible points are going to be 80 there. So I'm going to walk through a better example of this in a minute, but this kind of shows you that within each of the 4 groups, you've got selections and options. You have to pick a certain amount of things to be done, and you get a point scale based upon that. Okay. So one of the financials, what I want to do is kind of say, what if? What if you are a practice that sees 15 patients a day, so you work about 200 days a year, your average cost for an office visit is $200, you have 20% of your payer mix is Medicare, and you've got 20 physicians in the practice. Given the scenario, and this is not without the caveat of year one that has the flexibility, you can see your MIPS adjustment is going to be plus or minus 4% in year one and then go up to 9%. So if you were to just continue as is, it shows you that in year one, your practice would have $2,400,000 coming in from Medicare. If you do nothing, you're like right at the, if you do nothing, but if your performance is that you are right in the middle of the curve, nothing's going to change. You're going to get that same amount. If you're a low performer and hit the max, which is a minus 4% for year one, you're going to get slightly less money, high performers slightly more, and the highest performers a little bit more than that. If you qualify for the advanced APM, you're going to get this guaranteed 5%. So the risk kind of goes away if you're in that category. And that's kind of why if you can qualify for that, you'd want to be in that. Okay. As you can see, the difference over 5 years for the neutral people, if you say I'm not going to do anything, is you're going to end up with $120,000 less than you would have. And if you are a low performer, it's going to be close to $1 million less. Okay, so what CMS has done is it's actually run some models, and they've looked at how many different providers fall into certain categories. As you can see on the top line, the single practice physicians, about 100,000 of them. The aggregate impact that they expect in negative payments from the small provider groups is $300 million a year. Now, what this comes back with, what this infers is that as the rule is written today, if you're in a small group or you're a solo practice provider, you're the ones that are going to lose the money, okay? And so this incentivized, and it looks like it's an underlying thing, is to have organizations move to larger group practices. There's a lot more value right now. The final rule has taken feedback, and we're kind of hoping that they adjust this so they don't put the single providers out of business. Okay, so one of the other quick things I wanted to talk about is I had mentioned that the scoring is going to change. As you can see in 2019, quality is the big chunk. It's half of the score. Well, that group is going to go down to 30% in 2 years and stay there. So these will be adjusted over time. And the penalty, as well as the reward money at stake, is going to be going up every year. Okay, so a little bit about quality reporting. I kind of mentioned this in the example, but you need to pick 6 measures out of the 200 available. One of them has to be cross-cutting, which means there's different categories, and you have to have one that crosses the categories, as well as 3 population health measures. And that's for groups of 10 or more physicians. As I said before, the scoring, each measure is worth up to 10 points. 90 total points it comes out to for groups greater than 10 or 80 for smaller groups. And there'll be benchmarks put in place so that this can be adjusted over time. You also can get bonus points if you pick a high priority measure, and I'll show you that example in a little bit as well. For the resource use basics, organizations don't need to do a whole lot to change how they're doing things today. This is really just submitting your Medicare claims. What you want to do, though, is ensure that you are submitting them. There's 41 episodic specific measures that you're going to need to be providing. Okay, advancing care information basics. As you saw before, there's 50 points for achieving 6 objectives. This is similar to the meaningful use things you have to do today, but there's not an interim score. Either you pass or you fail all these categories. A couple of caveats to this is that for your reporting to registries, immunization is required, but then you can get bonus points if you submit to other registries. CPOE and clinical decision support are not required in this model. Just like meaningful use, you're going to have to provide numerator and denominator data, or yes or no. And one of the things that has been required is that you do your security assessment every year, and a failure to do this, and you get no points at all for this category. And then finally, advancing care information. Well, this is actually a little more detail about it. You have a base score that makes up 50 points, so that means you have to hit all these 6 requirements. Protect patient information, e-prescribe, providing patient electronic access, coordination of care, health information exchange, and then the registry reporting. So just by doing them, you get 6 requirements. You also can get an additional up to 80 points, depending on how well you did in all of those categories. And then if you want 1 bonus point, you can report to a registry that's beyond immunizations. If you go over the amount, you still only get 100 points. So you can do better there as well, but that gives you that full 25 points for that category. So once again, the point system is something you need to try to understand, as you have points within each category, and then you've got the whole composite point score. So advancing care information, as I said, similar to meaningful use. If you want to look at this, this kind of just correlates what meaningful use requirements are with the new requirements for MIPS, okay, for this ACI area. Security risk analysis, e-prescribe. Now, electronic access means you have to provide access to a patient, and include patient-specific information. Coordination of care includes some of the characteristics you had become familiar with meaningful use: view, download, and transmit, PHI, secure messaging. But they're adding that on your patient portal, you're going to be able to, or you're going to be required to have patient-generated health information. So patients can key something into it. Health information exchange covers a number of things. It's exchanging patient records, as well as reconciling clinical information across organizations. Now, for the public health reporting, as I said before, immunization registry is required. But you can get a bonus point if you do any of these three: syndromic surveillance data, electronic case reporting, or public health registry reporting. Okay, and the last area of the four is clinical practice improvement activities. There are 8 activity categories, over 90 activities. You don't need an activity in each category. And overall, my guess is most organizations are doing these already today. I'll show you a few samples, but you just need to pick 8 of them. Now, there's different scores based upon the ones you select. Some are worth 20 points each, some are worth 10 points each. The final list will be available when the final rule is completed in November. There are a few exceptions to accommodate certain areas. If you're non-patient facing, a small and rural practice, or you work out of a physician shortage area, then you don't need to pick as many activities. Okay, and this is just an example of ones we know are going to be there. So, for example, if you want to fall into the category of expanded practice information, if you have 24/7 access to clinicians and care teams for patients, this could be something like having a hotline that someone could take information and connect to a clinician. Then you would get 20 points. Okay, if you use telehealth, you get 10 points. So you have to pick enough of these. You have to pick 8 of these in order to come up with your composite score. I'm going to go back to that just a second. Just so this presentation will be available if you want to look at these. There's a lot here on this page for you to look over, but I think it'll give you a start to understand, can you do this? We also have references to the larger materials as well. Okay, so alternative payment models. There really are 2 categories, APMs and advanced APMs, and there's been a little confusion in the materials we've kind of consolidated. The one thing I think that clarifies it, if you are just an APM and not an advanced APM, that just means you belong to a group similar to an ACO. And if you do, you can submit your data as the group instead of individually, and you have to meet the MIPS measures. But if you do so, you'll get what CMS is calling favorable scoring. Okay. Advanced APMs, you have to belong to a specified advanced APM, and I will show you what the current ones are in just a second. You also have to use certified EHR technology. Your payments are going to be based similar to MIPS, and you have to bear more than nominal risk for monetary losses. For example, clinicians might have to, if they're in a depressed area, reduce their rates, withhold payments, or actually make payments to CMS when their patients haven't paid them. Okay, so there's a little bit more risk there. Also, you may be a medical home model expanded under CMMI authority, and I'll talk about that in a second. Okay, so the advanced APMs that are in place today, there's just 6 of them right now. The comprehensive ESRD care model, which is the large dialysis organizations, comprehensive primary care plus, Medicare shared savings track 2 and 3, a next generation ACO model, and an oncology care model. We expect over time that most providers are going to start in MIPS, but the number of ACOs that are going to be included to be added, we expect 21 additional ones of the next generation models across 13 states in the near future, and then the Pioneer ACO is going to be 9 additional spread across 7 states. So the medical home model, once again, you have a unique financial risk. It enables participants who are not excluded from MIPS to receive the maximum score in one of the MIPS categories. The key features here are that they have at least 4 of these conditions that are on this slide: planned coordination of chronic and preventative care, patient access and continuity of care. They coordinate care across the medical neighborhood. So this is where you have a team of providers that have been assigned to a patient to coordinate the care. There's shared decision making, and the payments arrangements really are in addition to or they're substitute for the current fee-for-service payments. So this is very similar to a lot of ACOs, the way they've been set up. But this is a legal thing that you file for and you become a medical home. Okay, so that's a little bit of background. We're going to get a little into what do I need to do to be compliant next. And I'm going to start by introducing Monica and talk about what Holy Family Memorial is doing today.
Right, thanks, Jim. So, Holy Family Memorial, we are an independent, single market, Greater Manitowoc County is our service area, tightly integrated healthcare system. We were founded in 1899. We're a faith-based organization with the Franciscan Sisters of Christian Charity. So we're rural, but we have an intense local and regional competition, especially with Aurora. We have 90-plus provider multi-specialty group practice under an employment model. So Holy Family has been a thought leader. I'm very privileged to be part of Holy Family under the leadership of Mark Herzog, our president and CEO, who recognized early, 6 years ago, the need to be innovative, cost-conscious, and to drive quality forward. So you can see we have been fortunate to win many awards. I'm very proud of our most wired 4 years in a row. And we've just recently been elected or voted as one of 100 great community hospitals for 2016 by Becker's Hospital Review. So again, our senior leadership was very thoughtful and recognized early the move from first curve fee-for-service to second curve reimbursement for quality and cost, and the need to engage the community in some health initiatives. And you can see the reference to that slide below. In December of 14, we service marked our care model, which is right care, right setting, and right outcome. Even though this model had negative financial impact for the organization because we moved services out of the hospital into a clinic setting, it was the right thing to do for patient care. So right care really drives everything that we do as the organization. And it allows us to deliver cost-effective, safe, high-quality care at low cost, which again, in a very competitive payer market, is what our insurance provider partners are looking for. We engaged BSG Analytics, who did a meta-analysis of all kinds of data, CMS, American Hospital Association, and others, and identified Holy Family among the most efficient hospitals in Northeast Wisconsin. So this slide shows we do deliver high-quality care at low cost, and that makes us very appealing to insurer groups. So our technology journey. Again, we were early adopters. In 2003, our Chief Medical Officer was also appointed as Chief Information Officer to leverage the technology and improve care and safety processes. This led us to be early and proactive. We've been functioning off of the Meditech platform, and realized that Meditech is not going to take us where we need to go as an organization, our leadership decided to move forward with Cerner, and our go live is planned for April 1st of 17. And the CareTech team has been phenomenal to work with in helping us with this Cerner readiness and go live target. And again, we were awarded Most Wired and HIMSS EMR recognition that we have deep IT and operations integration. Our IT strategic plan is aligned with the hospital's strategic right care and innovation plans. What all of this has done, it's allowed Holy Family to manage by data. We pulled together a MACRA readiness team. Brett Norell, our Chief Financial Officer, is the champion. I think that's very important to have finance as the lead because this is all tied to dollars. You can see that Dr. Driggers is our Senior Medical Advisor. We have the Director of Quality, her Quality Assistant, the Director of Primary and Continuity of Care, our Director of Health Information. Darren Pappas with CareTech is our Director of Information Systems. Myself and our new Chief Medical Officer, Dr. Polnow. We make up the MACRA readiness team. And we're key to getting the leaders on the same page at Holy Family and helping them move forward. One of our key tasks is to read, network, and digest and share the information with the rest of the leadership. So quality. Quality, like IT, is embedded in our organization. Our quality team works closely with our ops and leadership teams, and we make decisions based on factual data. The team, of course, tracks and trends, slices and dices, and puts forward improvements and works closely, again, with our leadership and our staff to facilitate those improvements. And one of the key components for our quality team is educate, educate, educate. Why is this important, and what does this mean to Holy Family? Where are we today as far as data? We feel we are well prepared for MIPS. That goes back to the deep embedment with IT and quality. We do have phenomenal scores for breast cancer screening, colorectal screening, diabetes management, hemoglobin A1C. We have a great program for tobacco screening and then offering cessation intervention, and the pneumonia vax for our older adults. We partner with the community when it's appropriate, and recently did a huge initiative with other healthcare providers in our community and the other agencies that support older adults, and significantly reduced deaths from falls. And we constantly work with IT to verify other measures and the accuracy of those measures and what could we be reporting. Primary care, we've done several things to enhance. It might seem simple, but we've come up with a single phone line for our primary care appointments. We currently have multiple locations for our primary care providers, and having a single line for appointments. If your primary care provider doesn't have an opening today, we can direct you to someone else. It might be at another site, but you certainly can get your care met. That gives us the same day access. We've implemented HFM right now, which is our e-visits, and we've recently expanded the conditions that can be managed through electronic visits. We have standard protocols, and we have a patient portal. And our current patient portal is going to be enhanced once we go live with Cerner. And the Cerner platform will also allow HFM to complete its certification process for a certified medical home. The IT, again, I can't stress enough how important IT is. It was really brought home when I spent my last 3 years prior to coming to Holy Family with a local health insurance plan. I was the director of Medicare operations, and no decision can be made without accurate, timely data. So IT is so important. It will facilitate the second curve care delivery. It will improve patient care and or safety. Information technology must support and accelerate our innovation and improvement activities. And we have a very engaged IT, both our internal individuals, our CareTech team, and Cerner. And CareTech and Cerner have been phenomenal in their consultative role, not only for MIPS readiness, but for everything that we do in the organization. So I'm going to leave you with one quote that drives home again what I've been talking about. He who has the data wins. And if anything, partner with the right IT team, have the right IT platform, and that will get you leaps and bounds in where you need to go for MACRA, MIPS, or APM readiness. Jim, I'm going to turn it back over to you.
Okay, thank you, Monica. Okay, so I kind of want to wrap up the presentation by just summarizing what organizations need to do from an information technology perspective to support MACRA. And I kind of want to, there's similarities in MACRA as there are most major initiatives in the healthcare world. This was a model that we've come up with that has helped us to support our customers in order to achieve meaningful use in a number of other regulatory initiatives. But in order to be successful, organizations need to not only put in the right applications and provide the right infrastructure, but the major things that will really foster success are culture, ensuring that your staff is trained and ready to perform what they need to, and really an emphasis on workflow and efficiency. So under culture, your organization needs to invest, make IT investments to support MACRA by having an adoption plan and engaging the community. Really have to work and transform that staff, much like Holy Family did, to have a quality mindset about everything that they do. As far as staffing, once again, Holy Family's success really came a lot from their stress on educating their staff on MACRA and understanding what they have to do and why. But you also need to be able to engage your vendors. They're very key in this. You need to have adequate IT resources, and you also have to have a support plan in place. As technology has been implemented, it's really increased the need to provide some kind of outlet where the staff can turn to somebody when they need help with IT functions. Workflow needs to go hand in hand with what you put in IT, and it really needs to be part of your implementation plan. Don't just put it in and hope for the best, but plan around how workflow is going to change to get the most out of things. One of the key things that's going to be very key with MACRA under applications is all the data that's available needs to be consolidated into meaningful reporting. So having dashboards and being able to drill down and select the measures and monitor them is going to be very key, as well as security measures for your IT and IT tools for patients. Once again, as we become very dependent on technology to really run healthcare organizations, it's very key that your data systems are quick and they're reliable. You've got disaster recovery built in, and you're using technology wisely, such as point-of-care devices to care for your patients. One of the key recommendations to get started, if you haven't done already, is to develop this initiative just like any other project. I mean, it really needs to be laid out with a plan, starting with assigning a project manager or a point person, and then understanding the rules, figuring out how this is going to affect you financially, and going through requirements by defining your scope, and then decide if you're going to do MIPS or an APM, or maybe transition it to it later. As of right now, you need to figure out what are the metrics that I'm going to have the best chance at being successful in. So you've got to analyze your data and see how you're doing today, and then put together the project team and governance to control this in order to be successful. education is going to be key, engagement of your vendor, and after that will come things like upgrading your systems to have the capabilities you need, and then implementing all those things you've defined for the 4 different areas. And lastly, continuing to monitor and manage this project plan. Okay, so overall, generally, what you need to do is figure out what you're going to measure, figure out your EHR capabilities, and then upgrade as you need to be successful there. Under the clinical practice improvement activities, this is totally up to your organization to select the ones they want to, but some examples are figuring out things like, do I do telehealth? Do I provide 24/7 access? Do I implement IT functions that are going to improve the patient experience, and so forth. For advancing care information, I need to do these things similar to the meaningful use areas, having registry reporting, a security assessment, sharing information, e-prescribe, and the patient portal with entered data and secure messaging. Under resource use, I'll have to continue to submit Medicare claims, but also measure the quality of the claims I'm submitting. And then for quality, I've got to be tracking core measures and entering numerator and denominator data for the quality. Okay. So finally, one of the key recommendations is, as you're moving through this, you need to develop dashboards so that you can track how you're doing in these and not just hope for the best at the end. So the project team should be implementing the measures and measuring them all along so that you can hit the thresholds that are required. There's a lot of resources that are available. One of the best places to start is to just go on your browser and put in MACRA and CMS, and it will take you to this website, and they have tons of information. One of the key things that CMS will do is help providers to achieve CMS, to achieve compliance. They've set aside a significant amount of money where they will provide support centers, much as the regional support centers they do today for practices, in order to be successful. Okay, and then finally, I kind of wanted to leave you on this note. One of the concerns I think that I've heard from a lot of providers is more regulations are going to cost me money and I just can't afford to do this. And so what we want to look at is, you've got a hospital, and I think this is going to be easy to guess because Monica already talked about this, but of all these large organizations that have a lot of physicians tied to them, an organization that has been very successful in achieving adoption of CPOE, inpatient and outpatient, growth their clinics, been a best hospital. It isn't just the main ones, but it is Holy Family, who's done this with not as much income as the others, not enough much resource money, a slim margin, but their culture has allowed them to be successful, and that's kind of what we think is the major thing that will help you to be successful. Okay, so we want to wrap it up. I think we got a few questions, but if you want to, you can use the chat feature and add questions, and we see what we can do. Okay, so I have a couple questions that we prepared, we can answer. One is, does MACRA offer any help for smaller practices? As I just kind of went through, that CMS has anticipated that smaller practices and hardship areas are going to need help, and what they've done is they've allocated money to have support centers set up through the CMS regional extension centers. There's also other ones that are available as well. And when the final rule is available in November, there'll be more information about this. Okay, for physician offices, not so much as a large organization, but there might be a challenge for how do you assemble a MACRA readiness team. In the physician offices, typically there's not a dedicated IT person. It's the front desk that is doing a lot of the work. And our recommendation for this practice is you're going to have to understand the rule and work with your staff to do that, and probably lean very heavily on the vendors to make sure that their products provide what they need to, and then work with your staff to see what are you doing today so that you can select the right measures. Organizations are probably in better shape than they think because they're submitting quality core measures today. They just need to figure out, are these the ones that I need to? And if you are achieving meaningful use, are you compliant today, then you're well on your way of meeting that area.
I agree with you, Jim. Absolutely.
Okay. Can a provider that starts in the MIPS category transfer to an advanced APM, and how would they do that? The way the program is starting, CMS expects most organizations to be in the MIPS category, or most providers. However, the advanced APMs are going to continue to grow and being expanded, and I think one of the goals is to be able to provide better patient care by having organizations collaborate through ACOs and group practices. So we see an advancement in this, and that's something that's anticipated. So on an annual basis, it's going to be very much like you submit your meaningful use compliance information right now. There'll be a website you can go to and select what am I going to be reporting on this year and begin that process. And associated with that is how do providers sign up for MIPS or APMs. There will be, much like meaningful use, a very detailed description and website with instructions where you will get your provider numbers, put them in, and then be able to select what you're going to pick. Once again, the details will come out after the final rule is published. And I do have one last question. Initially, MACRA only affects Medicare Plan B clinicians. If you have Medicaid mostly, or if you have private payers, what do I need to do? The good news for you is that you have more time to get ready. The reality is these same rule is going to apply to you down the road, that private organizations and Medicaid are going to have similar requirements that you're going to need to follow. So it'd probably be in your best interest to get started on this immediately. Okay, do you have any other questions?
I do actually have one here.
Okay, another question. How often should I have a risk assessment to meet the requirement? That's a good question because there was a lot of confusion around this regarding meaningful use and risk assessments, and it really is the same requirement. What you'll need to do is have a HIPAA certified risk assessment performed, and then on an annual basis you're going to have to review it and update it to ensure that you're moving along and have it reassessed. So the second time's not as big as the first time when you go through, but you need to keep working it. So it's a continual process. It's going to be a checkbox saying yes or no, I didn't do it, but then you're going to have to show proof if you're audited that you did this. Okay. Okay, if MACRA doesn't apply to hospitals, why is Holy Family spending so much time and resources getting ready for MIPS?
I can. Well, yes, we are a facility, but our physicians are in an employment model. And this applies to any physician who submits claims as an outpatient place of service. So that's why we've done so much. Plus, we know that this will strategically, it will prepare Holy Family, as Jim has mentioned, because other payers, everyone is going to quality and risk share.
All right, thank you, everyone. On behalf of the presenters, we do thank you again for your time today. We hope you found the information beneficial and your time well spent. Again, we will be sending out a short survey to get your feedback and any suggestions you have to help make these sessions even more valuable for yourself going forward. Thank you again for participating and enjoy the rest of your day.